Assalamu alaikum. Left main is one of the most important vessels and PCIs we deal with. It's a high risk. It's usually uncommon and it represents 2 to 4% or 6% of all PCIs. So really experience in these patients matter. The best way to approach left main is first to sit back, think, and take the opinion of your heart team or your colleagues. Failing to plan is always planning to fail in these patients. If we look at this example, this patient, there's a significant left main disease. There's heavy calcification, as you see in the left main and in the LAD, even seen by angiogram. The operator decided to go immediately and do PCI without further thinking or evaluation of the left main. So planning and evaluation of left main before PCI is crucial for success. However, the balloon did not dilate and it's as you see, deformed. So he decided to do IVUS, and the IVUS shows significant calcifications. It's superficial and deep, and it's more than 180 degree. So instead of debulking, he decided to take a larger balloon, and he makes his life more difficult in this situation. There's a significant dissection, as you see, and he deprived himself of the benefit of using atherectomy or a rotablator, and the final result is not really as good as it should be. We know that stent expansion is one of the major causes or predictors of restenosis and stent thrombosis. So PCI can be the best option in patients with left main disease, but you have to have the right patient, the right approach, the right evaluation, and the right technique. We know that the prevalence of left main is only 5 to 7%, and you have to know that both PCI and CABG can reduce mortality in these patients by 70%. It's not CABG alone, as many of us think. That's why the guidelines recommend revascularization regardless of the severity of symptoms. PCI is also increasing. If you see the trends, it was almost nil in the early 2000s, then 1 to 2% in the late 2010, and now it's approaching 60%. And also the outcome is improving despite the increase in complexity, comorbidities. However, there's still low utilization of intravascular imaging or debulking device, which reflects our failure to optimize PCI in left main disease. So PCI is still the best option. We always look and discuss the trial's outcome. We discuss MACE, we discuss mortality, but we never think what the patient wants. What matters to the patient? What matters to the patient when you talk to him is that his symptoms are relieved. And we know that PCI is faster to relieve symptoms, less pain, and there's almost immediate recovery. And we know that there's no difference in angina relief after 1 year. So in terms of symptoms relief, there's no difference between PCI and CABG. And the patient wants to live longer. We know that up to 10 years, there's no difference in mortality between CABG and PCI. He wants to live healthier, definitely, and he wants to live better. Again, PCI is less painful. There's no splitting of the sternum. It has less complications and comorbidities. And the quality of life is similar between CABG and PCI after the first year, but in the first year, definitely the quality of life is much better with PCI. And in overall MIs, there's no significant difference between both. However, repeat revascularization is more with PCI, but this is a misconception, as we will discuss later. See, if we look at randomized clinical trials, and up to 10 years, there's no difference in mortality, regardless of syntax score, especially in pre-compact and syntax 10 years result. There's no difference in cardiac death. There's no difference in MI. There's, of course, some difference when you base your definition of MI is different. There's no difference in stroke. But again, why should you expect PCI to reduce stroke? Stroke after PCI, after the index procedure, is related to the patient factor rather than to the stent itself. Again, why should you expect PCI to reduce revascularization in a vessel that's not stented? So TLR is what we should look at rather than TVR or repeat revascularization. And again, taking MACE as a whole is deceiving because MI and repeat revascularizations are different among different trials. So if we look at the randomized trials, there is no difference in almost all outcomes except repeat revascularization. The same if we look at the meta-analysis, which are multiple. This is one of the most comprehensive meta-analysis, and there's no difference in mortality, stroke, MI, only unplanned revascularization is higher. What about diabetics? Again, there's no difference between PCI and CABG in these patients, but higher MI and TVR. Again, the long term, up to 10 years, there's no difference in all-cause mortality. There's no difference in MI, no difference in stroke, only unplanned revascularization is higher. So PCI and CABG, at the end, they lead to the same outcome, but with less pain and less suffering to the patient. So should revascularization really be an end point? It should not, because it does not reflect a hard clinical endpoint. We know that in patients with CABG, most of the time when we cut them, there's no target to intervene upon. And this is a misconception that he did not have intervention. We failed to intervene in these patients because of lack of suitable target and because the PCI is most of the time associated with higher failure rate and high complications. That's why most patients after CABG are treated medically and they are regarded that they did not have revascularization. So again, what matters to the patient? This is what we should look at. What matters to the patient is to have less comorbidities. What about the comorbidities of CABG? They are never assessed in randomized clinical trials or even in observational studies. So can we achieve results like CABG? Yes, we can, with appropriate planning, doing PCI by expert. We know that outcome is related to the volume of the operator. The more experienced the operator, the higher, and the better the outcome and the less the mortality. Use intravascular imaging. The reduction in mortality is between 45 to 50%. Still, we don't use that. And if you don't use that, you don't expect to have results as good as CABG. And we know from meta-analysis of multiple randomized and non-randomized trials that there's significant reduction not only in mortality, in MI, in in TLR, in stent thrombosis, and in cardiac death. Again, optimize your PCI. It's very important that you reach the full stent expansion, no malposition, no edge dissection. However, we fail to reach this even with IBUS in up to 33% of patients. However, we know that the lift main size is different according to population and the size of the patient. That's why they came with the new optimization criteria, which depends on the distal vessel size, no edge dissection, and no landing at plaque burden more than 40. When you do this optimization, there's 75% reduction in almost all endpoints. So yes, we can reach results like CABG. What about DAPT? Don't give a short DAPT to a patient with left main bifurcation stenting or left main stent. In ESR main and COMET registry, they found that the best combination for DAPT is more than 24 hours, which is associated with the lowest mortality and morbidity. So BCI and CABG, they are complementary. They are not competitive. You have to know which patient is suitable for CABG and which patient is suitable for BCI. Not all can go for BCI and not all are candidate for CABG. So conclusion, with appropriate patient selection, technique, optimization, we can reach results better or equivalent to CABG. We should always consider what the patient's values and believes and what he wants, and we should always also consider the comorbidities of CABG. The patient need to know that both procedures are complementary. They have advantages and disadvantages, and each has indications and contraindications. However, there's no difference in outcome as a whole between both procedures. Thank you.